Well, thank you very much. We have a separate session on accreditation because of its power, or at least its potential power to change things, because we're all about change, or should be all about change. And the accrediting bodies can really not just catalyze, but really move this ball down the track. And it desperately needs to move down the track. So we have about 30 minutes for discussion. So let's start. I see Barbara waving at me.
This is a great example of how we bring thinking from one group into another group. I see my people smiling. And so I'm just going to talk and you can react and hopefully I'll have a question. But we really struggled with the issue of which model to choose for IPE, for the measuring the impact of interprofessional education on collaborative practice and patient outcomes. And I actually was feeling this yesterday, is at the end of the day, there also needs to be individual competencies as well as your team competencies. And, we're just at the baby steps at having this conversation. And so to me, we have to really start figuring out how to tease that out. So the number one request of the National Center is how to assess teamwork. And that's usually on an individual basis and whether you're able to function in a team and then function in a team in a specific context and then have outcomes. And so I'll give you a couple of examples. We get to see the struggles, and I don't mean that in a negative way, with the maintenance of certification. And what people are bumping up against is that the physician is required to demonstrate those outcomes, but the rest of the team is not. And then the rest of the team is a little bit concerned that the physician is getting credit for it. So I'm only bringing this because I think that's going to be the next level of conversation we have. And we're really trying to do that in the National Center. How do we collect those outcomes? And then we also have the complication of when you bring in the learners and residents into that. So I think at some point we all are going to have conversations about the IPEC competencies, and individual competencies along the continuum. And what's really exciting is those conversations are starting to happen. And just the last thing, because both of you represent the joint accreditors, we ourselves in the National Center are struggling with this mightily, is how to even do joint accreditation as a national center. For our own programs. So you can respond.
So I'd like to respond to the maintenance of certification issue because it was key to a discussion that our board had 2 weeks ago. And Kathy, I wonder if you can talk about evaluation as the issue that we're seeing in joint accreditation, because it could be something we all work on together. So our board at the ACCME had a session at their meeting where actually I had the opportunity to meet David. We invited 2 jointly accredited providers. Those are organizations that have demonstrated that they're teaching education by the team for the team. We had 3 accreditors, nursing, pharmacy, and physician assistants. And then we had what are known as the tri-regulators, the licensing body umbrella organizations in nursing, pharmacy, and medicine. And we talked about sort of the challenge that we have in that you can educate by the team and for the team, but then the individuals go off and get licensed and credentialed individually. So we have to come up with some way to recognize that education in fulfillment of the licensing and the credentialing. I think that it's something that we heard the licensing bodies are talking about as well, sort of how to assess the team and how to sort of move away from requiring the individual component to that. That's not to say that there isn't a need for education for the individual clinician. There's certainly a role for both, but sort of how to not make a real complicated system and in fact try to use a lot of these tools and resources to count for multiple requirements. Otherwise, we just continue to make everybody crazy. Yeah.
So speaking to the Oh, sorry. I think I was muting. Was I muting myself? That's great. So clearly, I'm not competent at this. With the jointly accredited providers, the criteria for developing educational activities, they have to be planned by the team for the team. So organizations don't generally struggle with pulling together a planning team that includes representatives of the target audience. They know they have to use evidence-based content. We do require that they incorporate or embed some interprofessional competencies within the educational activity, and they have to have an opportunity to learn from, with, and about each other. So there has to be some sort of interactivity. It just can't purely be a didactic type of lecture. But where they struggle is evaluation. And so we spend a lot of time talking with them about how do you evaluate, or what types of evaluation measures can you use for teams. And right now we're starting with things like a question that would be just indicate a single profession, or what we call just parallel play in education. You just have members from different professions in the room. A common evaluation question would be, well, as a result of participating in this educational activity, I'll change the way I take care of patients with hypertension. Well, I could argue that you can say that whether that's a single profession activity or whether that's an interprofessional activity. That doesn't reflect any part of the team component. And because our joint accreditation criteria say you have to measure competence or performance of the team or the impact on patients, they're having to shift that conversation or that lens through which they're evaluating. So things like, I better understand my role as a member of a team taking care of patients with hypertension, starts to move into that realm of at least assessing what is that individual's impact as a member of a team, or how does that team then influence the practice or impact on patients. And that's where we're starting now. I think what's nice is that we're seeing a building body of evidence with the jointly accredited providers that demonstrates what's the impact now on practice and teams. And we recently held a leadership summit, and I don't know, did you include that link? I mean, there's was partially funded by the Macy Foundation, and we brought all the jointly accredited providers together, and they gave us examples about what they've been doing and the impact that they've had in practice and on teams. And it's a powerful piece of work. It's an open source document on ACCME's website and on the Joint Accreditation website, so you could download it and really look at what these organizations are able to do in practice.
I want to kind of pick up a little bit of what's embedded within Barbara's question. And I think we've got to remember we've got credentialing and we've got licensure. And the two interact with one another, but they're driven within a different kind of legal framework. So one of the issues that I think is really important is some of the work that the regulatory bodies are now starting to do in relation to licensure compacts, where you are licensed in one state and you are privileged to practice in all of the other party states. And nursing kind of started this about nearly 20 years ago now, and we're now introducing the second generation of compacts. Last year there was 10 that went forward, 10 that went forward and were signed off by governors. This year there's 22 states that are moving forward, and 8 of them have already completed the full process, and we're eagerly awaiting the others. And I think that starts to help align some of these requirements, or at least blur some of the edges, because at the moment the licensing requirements, it's X number of CEs in this place and it's double their number somewhere else, and there isn't any somewhere else, and therefore we need that compact piece as part of enabling the dialogue. The second thing that NCSBN did back in October of last year was we convened an event called Regulation 2030, and we brought together, it was multidisciplinary, it was global, and we also had intergovernmental agencies there as well. So we had the OECD, we had WHO, we had the Federal Trade Commission from the US was part of it as well. And what we were trying to do was, what are the major regulatory trends that have occurred up to this point? And we were able to identify 25 of those. And then we said, okay, if this is where we are at this point in time, how do we accelerate that trend, or where is it going to take us to? And as a result of that, we've developed 25 consequence maps, which we're just finalizing and putting it together in a report, which will come out in June. So I think what we're seeing here is a willingness, not just within the US, but globally, to start to sort out some of these barriers that there have been in the past as we bring knowledge to the fore in terms of taking that evidence and what works and what doesn't work, and being prepared to at least consider, not necessarily adopt, but at least consider ideas from other disciplines, from other parts of the world to really accelerate, because our health systems are facing globally incredible pressures. And unless we start to really incentivize efficiencies within this, we are not going to be able to meet the needs of citizens at a national and global level.
I think the other thing, too, we haven't really discussed. Everybody sitting at this table is an accreditor in the educational setting. We have practice-based accreditors out there. A good example would be CARF, which is the Commission for Accreditation of Rehabilitation Facilities. You know, team-based approaches have been happening in rehab for over 50 years. It's not new to that community. That's the way it's always worked. And those outcomes is what those accreditors have always looked at, those competencies of the team in producing that outcome. So that when we're looking at what are those competencies from the perspective of the professions and those individuals, we have to take into consideration what those other agencies are already looking for in the practice community. Because to get the practice community to buy in, if they're already looking at those outcomes, they're looking at those requirements for that accrediting body, we have to make sure that we stay in sync with those requirements going forward. And we really haven't discussed that much at the table, though we did have them at the conversation we had on accreditation at the workshop last year.
Also had some discussion yesterday for at the members' planning meeting about bringing the practice side accreditors into alignment with the education side, the left and the right sides of the diagram that Miguel presented to. Many of you were at that meeting on Wednesday, but I know not all of you. So this issue, not only of Barbara pushing on team outcomes, but this issue of integration across not only the educational accreditors, but the practice accreditors. And there's even more of them when you think about the complexity of it. And that's why we brought into that discussion people from the practice accreditation side. So I think it's absolutely critical, both team outcomes and integration, not only on the one side of the diagram, so to speak, but on both sides and bringing them together. Other comments?
Yeah, I mean, you know, the other thing, and I think one of you mentioned it, the other force obviously is the boards and the specialty boards for many of these groups. I mean, obviously they are trying to defend their own turf, you know, for their paying members and the practitioners within that community, and how you align that group as well in terms of thinking about the outcomes for the patients. I mean, Atul Gawande had written an article in the New Yorker about one of the societies that deals with patients with headaches. And despite that society putting out best practices for how to approach this one medical issue, even within that community, there's such a lot of variety in terms of treatment options. You think about the diversity of treatments that you might receive in one health center versus the other. And so you have also those kinds of competing factors, I think, that we have to think about.
Another sort of integrative problem, isn't it? I mean, how do you deal with the credentialing and the accreditation groups, you know, the program evaluation versus the individual evaluation? And as comments were made by a number of the panelists, this is another critical integrative area. So bringing people together is really, I think, the main function of this forum and many of the Academy's activities, really, is to get people from disparate backgrounds around the same table. David, it looks like you had a comment.
Yeah, I mean, one of the things that we're doing on that is that we have a system called Nurses, which enables any citizen anywhere in the world, actually, to identify the licensure status of a nurse at any point in time. And it pulls data from all of the states that nurse has an active license in to see whether or not. We've just structured a memorandum of understanding with one of the credentialing organizations to enable their data to interoperate with the licensing data. Now, the advantages for us, our members, our state regulatory boards, is that they can see if they've given someone approval in an advanced standing, that they have an up-to-date credential as part of that process, and it interacts directly. The benefit for the credentialer, obviously, is that as they know that the regulator is looking at their currency of their credential, then it helps the credentialer as well, because people sometimes forget to renew and various other things. So it's a win-win for both NCSBN and for the credentialer, but it's a bigger win for the public, who then actually can go to a single point and then start to see the status of that individual in terms of what they've been prepared for and not. So I do think we are getting better with some of the technologies at bringing some of this information together and making it much more accessible to citizens in terms of knowing exactly who they're dealing with, and their clinical expertise that they have to bring to bear.
So a systems approach is really essential, and David reminds us that the licensing authorities have a fairly heavy role in this too, and so from an integrated perspective, they need to be brought in. Kate, I think you had a comment.
Yeah, so you raise two issues, maintenance of certification, for example, and data and what we can do with the data. So I won't go into a lot of detail, but for the past 18 months, we've been working very closely with the American Board of Internal Medicine, who was really faced with a difficult situation and sort of mutiny of their diplomates with respect to the robustness and variety of education that was available to support maintenance of certification that would count. And we've worked very closely with ABIM to sort of align the accredited CME system that's appropriate for internists with the MOC requirements. And I think that's helped sort of demonstrate that this workplace learning can count, and they don't have to do something different. So I think that's still a work in progress. We just started working with the American Board of Pediatrics and the American Board of Anesthesiology, and there's a couple of more boards that are interested. So I think that's an effort to sort of bring back together the education and credentialing processes in a way that's supportive rather than competitive. Data and health informatics, that's sort of the most amazing opportunity for all of us in both credentialing, licensing, and accreditation. And the idea that we can connect the data from EHRs, for example, and registries with education that will be appropriate to help promote the standards of care and consistency of care and treatment. So that, I think, that's a whole nother topic that is just wonderful to talk about in terms of how to make sure that we're working in sync with the health informatics folks.
Other questions and comments? Go on. I know it's been a long workshop, but I'm sure you have thoughts.
So Malcolm,
Challenges for the accreditors. This is your chance, folks, to challenge the accreditors to do things.
So Malcolm, just before we pick another question, I mean, that point about connecting electronic health records, in Portugal, the nursing order, as they call it there, the nursing board, gets a regular download at aggregated level of what nurses are actually doing in the country. So that then helps to guide the continuing education on the curriculum content that is required, because ICMP, which is the International Classification of Nursing Practice, is actually embedded within the electronic health record. So it actually sucks all that data and says, this is what nurses are now doing, and that actually helps to then shape the curriculum content for both pre-licensure and for continuing education.
Paul.
Yes, my question is for really all of you. We, each of you works in a system which requires a focus heavily on competency and measurement. And one of the topics that was introduced involved well-being. What we see, I think, is a question of education versus something else. So whether, if we're going to accredit organizations for something that involves maybe the mental health of the practitioners, then I'm interested in hearing the comments. I mean, it's often, historically, we've seen, resistance to conditions being medicalized, so to speak, if we go back to many years. I mean, the worry was that we were medicalizing social conditions, for example. In this case, I wanted to hear how each of you was thinking about helping the individual practitioner through the systems you're using through education.
Please, Kate, go ahead. All of you.
So,
I expect a comment from all of you on this one.
Paul, that's a great question, and it's something that is becoming increasingly at the forefront of what many of our organizations, ACGME and others, are focused on. And I think two things. One, the idea that education can be about more than the clinical care recommendations, but can be about professionalism and communications and how to be a team and how to be support to each other is completely appropriate in what we would say accredited organizations can offer. But the second is that if we can develop this really sort of robust education system and support it so that there's education going on in not just in classrooms but in the hallway. The example from VCU yesterday, I wanted to ask if those huddles in the morning at 8 a.m. were accredited CE, because they should be, right? And I think that connection, that ability to learn and be involved in education is itself a support strategy. It makes the clinician feel connected and part of a community, and I think will contribute to well-being.
So I think one of the examples I would point to is there was work that was done in Scotland about 15 years ago now called Balanced Working Lives. And that was work that was done jointly between employers, government, professional associations. And it was really to start to look at the work environment in terms of whether it supported well-being for the clinicians and those others that were working there, because a health system doesn't work just with doctors and nurses and dentists and pharmacists. It works with the porter and with the handyman and all of that as well. So that's one thing I would point to. When I was with ICN, the International Council of Nurses, we worked with the World Medical Association, International Pharmacy, Dentistry, and Physical Therapists, and we developed an initiative called Positive Practice Environments. And that drew on some of the learning that came out of Magnet and some of the other schemes that has really demonstrated that you cannot have a healthy and safe patient care environment unless you actually work with your clinical team as well. So those are a couple of examples I would give. I would also just say that yesterday's announcement from the World Health Organization of an 18% increase in depressive illness, and it's now the top cause of morbidity globally, makes us all think that we actually need to be doing an awful lot of more of that in a preventive sense throughout all of our systems. And I would reiterate the point I made yesterday in relation to the quadruple aim. The quadruple aim cannot simply be about what healthcare professionals do in attaining population health. There are so many other players there, and we have to reach out. And I think one of the problems we've got is that the Sustainable Development Goals, there is a goal in there of the 17 goals that is specifically about health, but we can contribute to all 17, and we're not seeing the dialogue and the discussion that needs to be in terms of how we as health professionals and we as the health system can actually inform environmental health and other types of agencies as well. So I think it's a great question. I think we need to do an awful lot more of that, and maybe that's something that in the future this group should be focusing in on.
So the American Nurses Credentialing Center is the credentialing arm of the American Nurses Association. So I think there's a couple things to your point of being able to use accreditation as a lever for change. There are 3.8 million nurses in the United States. So one in every 85 people in the U.S. is a nurse. Almost everybody knows a nurse. And nurses' health overall is subpar. They know what they should do, but they don't. There's a lot of environmental factors. There's a lot of personal issues related to that. But the American Nurses Association has launched a grand challenge. And for this year, it's Healthy Nurse, Healthy Nation. And the intent is if we raise the health of nurses in the United States, we can raise population health. And then by extension, their families, friends, the patients they care for. So to Kate's point, within the accreditation system, certainly continuing education that's directed at the health of the nurse, whether it's mental health, spiritual health, physical well-being, is certainly meets, the guidelines for accreditation. But David mentioned we also credential hospitals and healthcare systems organizations with a program called Pathway to Excellence, and that's about a positive practice environment for nurses, and by extension, all those who work in that facility. So I think there's about 195 organizations right now in the United States and actually internationally that are credentialed through Pathway. And then the Magnet Recognition Program, which is also embeds standards that promote healthy behaviors, nurses in control of practice, making practice decisions, which has had tremendous success and has been tied to positive patient outcomes in those organizations. So through those different levers, whether it's the CE system, whether it's hospital-based standards, we can demonstrate a positive impact on the health of nurses, on patients, and within systems.
Bill, any thoughts?
Yeah,
Oh,
just
yes.
that from the accreditor's perspective, you can certainly have requirements that address content and resilience, health and wellness of the workforce. There's no question about that. And we can we can require outcomes that reflect that this is actually happening. But the piece of the pie with this whole conversation, though, is it involves a culture change. And it can't be just from nursing, or it can't be just from OT, because nurses don't work in just a nursing environment, and OTs don't just work in an OT environment. They work in a healthcare delivery environment, in some places community-based practice, which actually working with underserved populations in urban environments in the community is probably a lot more stressful than in some of these other environments. So it involves a culture change across the system as a whole. And that needs to come from organizations like this, because individually as professional associations, there's a limited role that you can do within that context.
Thank you very much. I think we've reached the end of our time, which is too bad, because I had some challenges around community outcomes as opposed to just individual patient outcomes, and the challenge of really substantively involving patients and patient organizations. And I know some of you are doing that work, as we touched on a little bit yesterday. But there are a lot of challenges, but that's appropriate, because this is a very powerful group of people and a powerful group of organizations. And it reflects the fact that we made a wise decision a long time ago, and that is to delegate accreditation and regulation largely within the professions. Now those professions need to get together and do it collectively. So thanks to our 4 distinguished panelists and for your attention.